It's go live. Here we go. Here we go. You are live. We're live. I'm Dr. Torrance. This is Dr. Zakas. We are here on the Ask the Doctor series, and I'm about to go live here. We're going live there. We've got a lot of different streams going live. We're trying to make sure that we bring to you what you need. Dr. Zakas was just at OCOM, which is Orlando College of Osteopathic Medicine. Super pumped and excited. Dr. Hasty, thank you for hosting Dr. Zakas. And he's in the Winter Park office, so that's why he went up there and worked with them and taught him a little ultrasound. Tell me a little about that experience, Dr. Zakas.
Yeah, it was wonderful. The students were great, and all of the student leaders of the ultrasound, orthopedic surgery, and sports medicine interest groups are fantastic. They gave me a tour of the facilities. The facilities are unbelievable. This is the only second class in right now. The school was just finished a couple of years ago, so everything is state of the art, brand new. They have facilities there and technology there that you and I couldn't even have dreamed of, Dr. Torrance, when we were in medical school. It really is like something out of Star Trek. So kudos to them for making an unbelievable school. It was fun teaching some students, their first year medical students. So they were very busy and very stressed. I remember how stressful that year was. So I appreciated them hanging in with me for a couple of hours just to kind of look at some knees and elbows and shoulders and wrists. I think that's what we got to. But yeah, it was a great experience. Like I said, the students were great. Everybody was amazing. And they hung in with me for a long time. And I think they're like 3 weeks away from finals right now, I think they said. So it's getting it down to crunch time there. But it was a great experience. Can't wait to do it again. And I think if any students are looking to go to a DO school, they should definitely look into OCOM.
Awesome. Great push there. Dr. Hasty and I serve on the Florida Osteopathic Medical Board, and that's how I sync you guys up. So, Dr. Hasty,
thank you for that.
Leader and mentor to all those students, and grateful to have him, respond to me and get everybody get you out there. So, one of the things I wanted to bring up is I find that patients have been told that they need surgery, spinal fusion, right? And this is definitely something that a person comes in. I need spinal fusion. Like, I'm getting told that I need to do this to save my nerves. What are the what are surgical emergencies where spinal fusion is the necessary answer? And let's start with that.
Sure. So I'm not sure that fusion is always the answer. So typically what will happen is if there is a patient who has bowel and bladder issues because of a mass, a large herniated disc, something similar to that in their lumbar spine, and they're losing their bowel and bladder function, that typically is a indication for an emergent lumbar surgery, a decompression. Now, whether or not the surgeon decides to do a fusion on top of that, my understanding is this is typically decided based on how much bone has to be taken out and how much instability there will be. So oftentimes they can do laminectomies and decompressions. They don't actually have to fuse the bones. Sometimes the fusion is added because of the instability caused by the removal of the bones. Now, this is not something I've looked at probably in the past year. And as you know, medicine changes quite rapidly. So I'm not sure if the opinion on this has changed recently. But for me, if I see a patient, they're having bowel or bladder changes, that's usually an emergency room visit, and then the neurosurgeon has to decide from there. So sometimes those patients end up with fusion, sometimes they don't. Seems like more often than not they do, probably because they need to have a wide decompression to save their bowel and bladder function. For surgery in general, if a patient is having progressive leg weakness from a sciatica, a pinched nerve in the back, those patients typically do become urgent or emergent surgical candidates to save muscle wasting that they'll not be able to get back once they recover. But a lot of times those patients can get away with a smaller surgery, typically a laminectomy and discectomy. Those patients don't always end up needing to be fused. So those are kind of urgent and emergent. And then I would say your kind of more chronic conditions where you see a lot of fusions is instability. Somebody can have severe degeneration in their spine that can cause a spondylolisthesis, or usually on the younger side, they can have pars defects in a severe spondylolisthesis. That's one vertebrae slipping significantly over the other. In that case, we get flexion extension x-rays to see, is this segment unstable? And then if it is, sometimes those patients can benefit from a fusion, but typically that's not an urgent or an emergent category.
Yeah, and that's something that we want to make sure that patients have a second opinion from. Hey, you have been told you need a spinal fusion surgery. You need a laminectomy. You need a discectomy. unless it is an emergent surgery,
Right.
need is an elective procedure. What does an elective procedure means? That the symptoms that you're experiencing are not something that's emergent, that needs to happen urgent to emergently.
Right.
And that's that we find that a lot of times patients come in and they're like, doctor, my doctor told me I need an emergency surgery. I was like, well, you're losing your bowel and bladder. Like you're in, it's like, no. If that's not happening, these are urgent, not emergent.
Right.
And they are not something where you have to have it. That's one of the biggest things I like to make sure that patients are aware that there are options. And if you haven't had any injections at all, and it's not an emergency surgery, I would definitely advocate for you having a set of injections, whether it's from us or from a pain doctor. I think that you want to make sure that you get a secondary consultation from somebody who's not a surgeon.
For sure. Yeah. And I would say anybody who at least has one surgeon tell them they need surgery and it's not emergent or urgent, I would say always get a second opinion anyways. I think a lot more spine surgeons now are smartening up to what the literature actually says about these surgeries. At least that's the way it seems to me. And the surgeons that I have always hung with in my circle were pretty conservative and honest in that regard. But absolutely, if you're not in the emergency room and they're telling you it has to happen right this second, it's probably not an emergency and or urgent. And most of these back surgeries are elective. And for the most part, we see because people are having pain. They're having either pain in their low back or they're having sciatic pain down one of their legs. And those are the symptoms that are leading them to see a surgeon in the first place. And the surgeon says, okay, well, this surgery could probably help you. And that's usually how it happens. So, or if the surgeon says, I don't think you're a surgical candidate, surgery can't help you. There is no surgery for this condition, such as with an annular tear. There really isn't a surgery for that. There isn't actually really good conservative, insurance-based treatment for that condition either. Those are also patients that can do great seeing us.
Yeah, annular tears are sometimes missed too, and that's something that always make sure that the clinician's looking at your disc and images. That's something that I tell patients all the time. If they're not looking at your images or they're just looking at a report, please bring those images. It helps the clinician to make sure that they're giving you the best assessment possible. If you're just giving somebody a report, love radiologists. Unfortunately, they don't have the opportunity to examine a patient. And an examination is very, very vital. And a history and physical is very vital for a lot of these patients because sometimes these radiologists are reading in a dark room and never, ever encountered the patient besides their imaging. So
yeah, for sure. For
sure. So that's one of the things I definitely want to talk about. Like it's kind of my second opinion series where we're talking about surgeries that can be avoided and or at least get a second opinion, taking a look at it. Knee replacements always going up. More patients are overweight. More patients have metabolic dysfunction. We're seeing a lot of those patients. What would you recommend to somebody with a knee arthritis that needs, is having, pain, 3 to 7 out of 10 pain, where it ebbs and flows. End of the day, it's getting achy, throbbing, and they've been told they need a knee replacement and steroid injections aren't working. What would you say that a person could have help with us?
So we are, we're one of the best clinics in the world at doing bone augmentation for severe knee osteoarthritis. So when a patient comes in, typically their surgeon just takes x-rays of their knee. They see they are bone on bone or they don't have a lot of joint space left. And they say, okay, you need a knee replacement. And knee replacements do work well for a certain population in general. It's a good surgery. It's relatively effective. It doesn't work well for everybody. If you have good range of motion in your knee and good flexion of your knee, despite the fact that you have severe arthritis, you may be disappointed by losing some of that. That's what happened in one of the things that happened in my mom's knee replacement. And if you're relatively lower functioning, then maybe that's a decent trade-off. But a lot of our patients come to us with arthritis that's severe in their 40s, 50s, and 60s. They still have a lot of good years left, and they don't want to go the metal route and have to have another knee replacement before they get into their 80s or 90s. And so our bone augmentation procedure really is both cutting edge, but also has 15 years of research behind it. And so when you come and see one of us, we will do a history and physical exam and ultrasound of your knee to see a lot of the structures on the outer part of the knee. And we also get an MRI to identify where the bone marrow lesions or BMLs are in your knee. And when somebody has bone marrow lesions in their knee, typically it's around the area where the worst of the arthritis is, but not always. And typically it's on one side of the knee or the patella, but also not always. And on my Instagram, I'm going to put up a video here the next week where somebody has bone marrow lesions kind of in the middle of their tibia. And then you can see on the x-ray picture how I had to get the needle into that area. But in general, these bone marrow lesions are painful. When somebody has one of these, the research shows they're about 8 to 9 times more likely to want to have a knee replacement because their pain is so severe. So with the bone augmentation procedure, we can take your stem cells and other healing cells from your own bone marrow concentrate, and then under ultrasound and x-ray guidance, inject them into these bone marrow lesions, and that can stimulate healing of them over weeks to months. And patients typically are so happy they don't want to get another MRI, but oftentimes you can get an MRI 3, 4, 5 months down the line, and you can see that these bone marrow lesions have healed, or at least are considerably smaller. We combine that with a comprehensive approach to treating the knee, including the ligaments, tendons, and joint surfaces, as well with PRP, high concentration, and also bone marrow aspirate. So when you come and see us, you get the whole joint treated. In Dr. Hernegal's 15-year studies, he just injected the bone marrow lesions, and impressively, that was able to prevent 80% of those patients from seeking a knee replacement for the duration of the study, which was 15 years. So that's as long. So this is as well studied of a procedure as anything we do in regenerative orthopedics. So that's why I tell patients, hey, this is cutting edge, but it also has a lot of research behind it.
Yeah. And I would be hard pressed to find any knee replacement study that I don't think there's many knee replacement studies that go that far out. They usually are getting a second replacement at that point. That's one of the biggest keys here, is why if somebody's in their 40s and 50s, somebody's telling them they need a knee replacement, I would highly recommend looking into our procedures to give you another 5, 10, 15 years, because the lifespan on a knee replacement is really 15 years ish. And
right. Yeah.
And there's not, you don't have the mobility that you have when you have your native knee. It is a new knee. It's not the same knee that you had, and it will be stiffer. It's not going to have the range of motion that you typically have if you have good range of motion. Now, some patients need it, and some patients, like about 20 to 30% of patients, they have a morphology where it's not doing well. Again, we discuss risks and benefits with all of our patients to make sure that those risks are discussed and benefits of the procedure discussed, to make sure we have realistic expectations so that somebody can get better. So that's definitely a secondary consult that I think that is definitely worth the come by and take and check us out in Sarasota, Tampa, St. Pete, or Orlando. All right, so let's flip the switch. So spinal fusion. We talked about discectomy. We talked mostly about lumbar. What are your thoughts about, there's a lot of, there's cervical and thoracic stuff, right? You and I really have been really doing a lot of work in the, mid to upper cervical space, and we see a lot of symptoms that people get whether it's their head feels like they're on a bobblehead, brain fog. What would you say to somebody who's had cervical steroid injections and they're continuing to have brain fog, and they're looking at maybe a C1 C2 fusion? I think that we have a great option for them to try to help stabilize and go from there. What are your thoughts?
Yeah, so these patients do come in, and typically if somebody has brain fog, they have these other associated symptoms that aren't just neck pain. That's when you do have to be suspicious for upper cervical instability. And so one of the most appropriate tests, in addition to getting an MRI at that point, is to have a digital motion x-ray. And so we do have a place kind of closer to where Dr. Torrance is that we trust to do a good digital motion x-ray that can figure out if you're having some instability either side to side at your cranial cervical junction and or forward and backward. And so when patients have these, a good first step is to go with the posterior injections, which is something that many of us do in our group. And that is including the C1, C2 joint, since there often is a lot of hypermobility there. And then we can inject those facets and ligaments to help stabilize and strengthen the neck from C1 down to C7 to the cervical thoracic junction. Now, if those injections do not get the patient to where they want to be, and they do have some significant cranial cervical instability, upper cervical instability on their DMX, and right now that's where we would send somebody to Centennial Schultz Clinic in Colorado for the PICL procedure, since right now they're the only people in the world that are doing that.
Yeah. And it can be a game-changing procedure. I just had a patient follow up about 12 weeks, 12 to 14 weeks out. I can't remember exactly, but he had issues with bowling. He's a longtime patient of mine. And so when he would look up, he'd get disoriented, wouldn't, kind of dizzy. And he's 50 to 60% better at this point. And
Excellent.
he's definitely somebody that I'm super pumped to see that he's doing well. He's a lot less brain fog. One of the objective findings that this is pretty cool, Dr. Zakas. So he has an implantable device, right? He has, and he had his device interrogated. And for the last 8 weeks, he has had no incidents of arrhythmias.
Interesting. Okay.
Right. So talk about vagus nerve and getting deep into that, right? So he had no arrhythmias, and he's like, this is the best he's felt in years. So super, super cool.
Was this a PICL patient, or is this somebody who you did posterior?
I just did posterior.
Nice.
Gentlemen, C1, C2,
Sweet.
brother. So
awesome.
Pretty cool stuff. Got him a lot
amazing.
more stable. Yeah. So that's objective data showing that he's not irritating that vagus nerve, which can cause some dysfunction and arrhythmias and that kind of stuff. So pretty cool.
There's a lot to learn about this area, and Dr. Centeno has obviously been the pioneer in this, and his content on YouTube and Instagram is incredible, and I think there's a lot more it's going to continue to come out here about other symptoms that are being caused by upper cervical instability. And, having multiple treatment options for this now. Upper cervical chiropractic can be great for some of these patients if they don't have too much instability as well. That can be miraculous for patients. And it's a really cool field. It's almost an entire field unto its own. But it's a great thing to learn about. You're learning about it. I'm learning about it. And we're all kind of on this ship together, which is a lot of fun. It's making a huge difference in people's lives.
Yep. I was fortunate enough to be able to go to the orthospinalgy conference this past weekend. Where there's a lot of upper cervical chiropractors, Dr. Laura Weller, Dr. Julie Hunt, Dr. Silver, Joshua Silver. These are people in the St. Petersburg area that my wife actually works at the Weller Clinic, and she has her own practice, but she's been doing a lot more orthospinalology. So it was interesting just to kind of go out there and meet with them. So it was super good to see. And one of Dr. Lieber's patients was mentioned by Dr. Hunt, and it was fantastic outcome for that patient who was having some ridiculous symptoms down the arm, and was told that they really needed a discectomy, and they are now sitting, with very little symptoms, not having a discectomy. Dr. Lieber did our platelet-based procedure to help the patient, and they're doing much better. So there are options for patients who have been told that they need discectomy, surgical anterior decompression infusion. Those are big surgeries, and they aren't without risk. So please reach out to us for a consultation. Dr. Zakas, myself, Dr. Lieber, Dr. Pappas, Dr. Velastro, we're all very highly skilled cervical injectors, and we can definitely see if we can help you. If we can't help you, we'll definitely send you the right direction too. So
absolutely.
So all right. Well, any hot topics, any good cases you came to recently?
Yeah, I had a couple great ones this week. One was a patient who she was fused from L3 to 5, and L3 to her sacrum.
Ooh,
and she was developing significant sacroiliac joint pain. So she actually had some screws. She had lucency around her screws on CT scan. And so I sent her back to her surgeon. I said, let's just see what the surgeon says about that first. And the surgeon agreed with me and said, I think her pain is actually coming from her sacroiliac joints. And so we injected those, and she's doing great now. So we inject the sacroiliac joints. So sacroiliac joints were obviously where so we can show them on the model here. And sacroiliac joints, that's them. So they typically get stressed out when the lumbar spine is fused, because that's the next segment down, particularly if you're fused at L5S1. And when you walk and twist and do anything, they're going to take on extra stress. So these joints can become arthritic, or they just become loose because the ligaments get loose from chronic stress. And so we inject these under fluoroscopic guidance. We can actually get into the joints themselves, and that can help hit some of the interior capsule as well. And then we do posterior injections, typically with a high concentration of platelet-rich plasma, to try and strengthen the ligaments and tighten them up so there's not as much micromotion in those joints causing the pain. So that's something where it's like, we don't get to the patient before the surgery, but we can help ameliorate some symptoms after the surgery. So that's one that I had recently that was pretty great.
Awesome. Excellent outcome. Excellent results there. We see it all day in, day out. And if you think that you need a consultation, we do telehealth consults. Florida is a wonderful place to come for medical tourism. We take those consults. We would gather all your records, your data, do history and physical, and we can talk and see if you're a candidate, right? So that's how we start the process. So if you want to come see myself, Dr. Zakas, Dr. Velastro, Dr. Pappas, or Dr. Lieber, and you don't happen to live in close proximity to us here in Florida, we're happy to get you on for a telehealth consultation and determine whether we have anything that can help in your case or in that type of thing. So there's a lot of any image guided injections, what we're specialists in, really, and we see such fantastic results with it. So super pumped about that. Let me see what other thing happened this week. I love knee patients who are doing fantastic. They seem to do super well. And Dr. Herdinghau's work is really, really great. So, Dr. Zakas, I mean, if you're okay with it, I think we call it a day. But great for everybody who popped on here. We're going to send these out as some social posts. So again, Sarasota, Tampa, St. Pete, and Orlando. And if you have any questions, that we can't answer on here, direct message myself, Dr. Zakas, Regenix at New Regeneration Orthopedics of Florida, and we'll be sure to get back to you and answer any questions you might have before you schedule a consultation. We're super open. We want to make sure that we're super transparent, and we get you in to understand what we can do or can't do for you. And that's really one of the biggest things. You're going to get a good opinion. You're going to get an hour-long consultation. We're going to take time with our patients. We're going to put our hands on you and determine where we think that the root cause of your issue is coming from and go from there. So Dr. Torrance, Dr. Zakas, any final words?
No, I'm good, my friend. I appreciate it. Thank you so much, Dr. Torrance.
No problem, brother. Well, listen, everybody have a great night, and we'll talk soon. All right, bye.
Have a great night. Bye-bye.